Hi guys, this is part 2 of Thursday's lecture. It's still week 9, it's still winter 2021, and let's get into direct inguinal hernias. We just talked about indirect inguinal hernias, so these are the direct inguinal hernias. So we've talked a bit about them. So these are the ones that are typically seen in older people. It's because of fascia in general gets loose and it's just not as strong as it used to be. And the hernia will push its way through a specific place called Hesselbach's triangle. We looked at Hesselbach's triangle before, so this is a P to A view. There's Mr. Bill helping us there. And we have the rectus abdominis muscle. Lateral to the rectus abdominal muscle is the medial border. The question could say medial to linea semilunaris, which is the tendon that kind of goes on the outside of the rectus abdominis muscle. The inferior portion is, of course, the inguinal ligament, and the lateral, kind of superior lateral portion would be the epigastric arteries and veins here. And that makes up a triangle, and that's where direct inguinal hernias occur. Remember, indirect inguinal hernias occur here, where intestine will push through the deep inguinal ring. Right, and I remember direct, always have this picture in my brain when I think indirect. I think direct hit, a bullseye, like if this is a target and you're playing darts, and that's the bullseye, direct hit in the target, or in the bullseye. Direct hit is a direct inguinal hernia. Right, and so here is, we've looked at this before, are the layers of that surround the inguinal canal and the spermatic cord and the testes, and we've seen them come down through here before, through the deep inguinal ring, but this time it's coming down through that weak region called Hesselbach's triangle, and it can still push its way out of the superficial inguinal ring, but it can never get down. It's impossible for it to get down into the testes. Alright, so it's always an acquired weakness from the process of aging. People with jobs or conditions that constantly increase the inter-abdominal pressure, like people with COPD who are coughing, people who are, what about people who are obese? No, remember, that's strangely, even though obesity increases intra-abdominal pressure, it's still protective against direct and indirect inguinal hernias. Not true for all other types of hernias. The connective tissue disorders, anything that weakens tissue, you're at risk for these types of hernias. You can also get it not over time, but you might get it in one single lifting incident. So, I mean, you could have these conditions and not have a hernia, and then you go lift something that's way beyond your capabilities, and the huge pressure just overcomes the tissue, and it herniates through Hesselbach's triangle. And as I said, it can push its way through the superficial inguinal ring, but it can't go through the deep inguinal ring. By definition, that's an indirect inguinal hernia, and it never descends all the way to the scrotum. Don't say that word very often, but that's one time you can say it doesn't get into the scrotum. Or it doesn't go all the way down to the labia majora in females either. It never causes a hydrocele either. So people don't have hydroceles with this condition because there's no way a hydrocele is a buildup of fluid in the testes or around the labia majora, and there's no mechanism for it via this method. Although you can still have a hydrocele independent, as we'll see. We'll talk about hydroceles here in a second. But not the congenital hydrocele. Can they strangulate? They usually don't strangulate because the intestines are moving through a very wide just weakness in Hesselbach's triangle, so they don't get pinched off as much as they normally would if they go through that tiny deep inguinal ring. It's a very tight squeeze, so strangulation is much more common in indirect hernias. Okay, there's a female, there's mons pubis would be here, there's pubic here. Labia majora would be right down in this region. So clearly it hasn't made it all the way down to labia majora. Inguinal ligament would be right about here, and it is above, mostly above. So that is a direct inguinal hernia in a female who was doing spring cleaning and lifted something heavy. These pantaloon hernias, for whatever reason, this platoon, I guess the L and the loon here, that for my mind, I've always remembered pantaloon hernias as platoon hernias. And they're a double whammy. They're having a direct and an indirect hernia at the same time. So that's a platoon or a pantaloon hernia. That's all we'll say about that. We do need to talk about hydrocele, though, because that's quite a common problem. And a hydrocele means you get an accumulation of fluid in the tunica vaginalis cavity, or the cavity for the tunica vaginalis. Remember we said that's between the parietal and visceral layers of the tunica vaginalis. And just like cardiac tamponade, it can fill up and fill up and fill up to the point it pinches on the testicle and the arteries, and you can get a testicular pain and ischemia from this thing, just like a cardiac tamponade type of deal. So there's two types of hydrocele. These are high yield board stuff, of course. A simple hydrocele and a congenital hydrocele. So let's look at a simple hydrocele first. So this one has, simple has nothing to do with a patent. Has nothing to do with the patent. My mind just blanked out. The patent processus vaginalis. Oh, jeez. Right. This is the processus vaginalis. It's degenerated away, so it's got nothing to do with that. It's a local problem within the tunica vaginalis cavity itself. So the congenital hydrocele is a patent processus vaginalis, or processus. Why can't I remember that all of a sudden? That's right, vaginal processus vaginalis. But let's talk about this. I'm concentrating on my brain fart there, or my gray moment, or senior moment. Anyway, so we know that this tunica vaginalis cavity is filled with synovial fluid, or cerebral, or not cerebral. God, jeez. It's filled with fluid that comes from the cells, just like the peritoneal cavity and the pleural cavity. They have a serous membrane that releases a serous fluid, and it prevents friction, so your testicle can slip or slide around inside the scrotum without getting heat friction on it. And so there's also a lymphatic system around there that drains. You can't see the microcirculation, but there is a microcirculation that drains. Let's go back to this picture. That you can't see, but there's a microcirculation. Let me see, I think I can draw here. Processus vaginalis there. I got it confused with tunica vaginalis. Anyway, so this is the parietal layer of the tunica vaginalis. This is the visceral layer, and that secretes a serous fluid in here normally. But what you can't see is there's a microcirculation in here. I'll just draw it as a single line. But that drains that fluid out, and there's a lymph capillary in there. We can make that in green. Lymph capillary, which can drain the lymph fluid away. And it goes up and dumps into the panpiniform plexus, and there's lymph vessels, and everything drains out of there. Just a very similar story that we've said before with regard to drainage of any tissue, any interstitial fluid type tissue. So there's the lymph system, a very intricate lymph system also within the spermatic cord here, and dumps into the panpiniform plexus, which of course you know what that is already. So these simple hydroceles are typically caught in children, older children and adults. Has nothing to do with a persistent processus vaginalis. That's the congenital type we'll look at here in a minute. processus vaginalis must be atrophied shut in order to have a simple hydrocele. Period. End of statement. So the serous fluid, again, it builds up in the cavity, and if it builds up faster than the lymph can drain it away, you start to accumulate swelling in that cavity, and it can get really, really big. Okay, swelling has nowhere to go. The processus vaginalis is not open, so you can't push the fluid up into the peritoneal cavity because that's been closed. So it grows and blows up like this. Right? There's a simple hydrocele in someone with epididymitis, and yep, that can definitely happen. And it doesn't have to be in the tunica vaginalis cavity either. I don't think I said that in my notes. But it can also be in the sac of the scrotum as well, because that's a closed sac. That has no way to communicate with the abdominal cavity or the peritoneal cavity either. So if you get kicked here and you bruise and you bleed inside, it doesn't have to be within the tunica vaginalis cavity either. So what are some of the causes of simple hydrocele? Epididymitis is classic. It's an inflammation of the epididymis. You can have filariasis. We already know filariasis loves the lymph system. How does that, what's the mechanism? I'm not even going to write that down. I assume you know what the mechanism is. If the mechanism here is not so much an inflammation in the tunica vaginalis cavity, which would stimulate the cells of the tunica vaginalis membranes to overproduce serous fluid. In this situation, just the regular production of serous fluid can't be drained away because filariasis, the bugs have gotten into the lymph system. We've talked about them before. It's like a beaver dam, and the lymph vacuum cleaner system doesn't work. And so you swell. Malignancy, testicular cancer, can also get into the lymph system and clog that up. Or a tumor can pinch off the lymph system. Either way, you have a beaver dam, and you can't drain the scrotum or the cavity, tunica vaginalis cavity. Again, trauma causes should be eye intrascrotal bleeding. Status post surgery can do it. Testicular microlithiasis. So that's interesting. It's really rare though. But sometimes you can develop calcium stones in the interstitium in the tunica vaginalis membranes underneath them. They're living cells, right? They have an interstitium that feeds them. And sometimes some people develop stones in that interstitium which can start to clog the microcirculation up, and you can't drain it. So those are called testicular microlithiasis or scrotal lifts. Is that right? L-I-T? Yeah, that's right. Lifts or scrotal pearls is another one, but it's pretty rare. But it can cause a simple hydrocele. The pathophysiology is well, we talked about it really already. The irritated mesothelial lining. All those linings of the pericardium, the pleura, the peritoneal cavity, those linings are called mesothelial linings, right? They have an epithelium, which is a serous. They're epithelial cells that secrete serous fluid. They have a basal lamina underneath them. Basal lamina and epithelium together make up this mesothelium lining. So mesothelioma's condition of the 3 P cavities. Actually, we know a 4th P cavity now, this tunica vaginalis cavity. But if you get an overproduction of serous fluid, it can't be drained away, and there you go. Even if you have an injury outside of the tunica vaginalis cavity and just get blood in the scrotum, you still can't, some conditions you still can't drain it away either. If the swelling is so much, it just overloads the lymph. Right, but here's a classic look here. So this is the tunica vaginalis cavity. Is just way, way bigger than normal, completely filled by serous fluid. And yeah, that's a simple hydrocele. The lymph drainage system is completely overwhelmed. Epididymitis, should say a word about that. That's an inflammation of the epididymis. It's typically secondary to a bacterial infection that has crawled all the way down the urethra and ended up in the testicles, and it gets got into the epididymis isn't super well vascularized, so the white blood cell army doesn't patrol that area very heavy, so you can get an inflammation there. And yeah, so that can do it. That's what it is. That's a fairly common form of simple hydrocele. And filariasis, we've talked about that before. That's just a parasite down in tropical climates, usually more common. And this particular parasite loves the lymph system. It'll get in there and clog it up. All right, now we rarely already talked about congenital hydrocele. Sometimes it's called a communicating hydrocele. Occurs in about 5% of children. And the cause is a patent or persistent processus vaginalis. So that communication between the peritoneal cavity and the tunica vaginalis cavity is open. So you can dump serous peritoneal fluid, can start to seep down there, and on top of the already serous fluid that's produced by the walls of the tunica vaginalis cavity, it starts to swell up with fluid. And that's what that is. You're born with this problem. Right? The simple you're not born with, but the congenital you are born with, and it's a persistent processus vaginalis. So fluid can easily build up in there. It's usually a complete failure of the processus vaginus or vaginal process to generate away. So you can have a lot of fluid easily getting in there. These patients are also, unlike the simple hydrocele, these patients are at risk for a direct inguinal hernia just because of the patent processus vaginalis. All right, the fluid buildup is not caused by an irritation of you could have prostatitis, or you could have an infection down there too. I mean, you could have two things at the same time, but classically it's not. It's just because of the persistent processus vaginalis. And here is a little guy who had this congenital hydrocele. So we can't see it, but inside there's a full processus vaginalis that communicates right with the peritoneal cavity, a huge pipe, and it's accumulated fluid, and now we can actually see an expanded tunica vaginalis cavity filled with serous fluid. Whereas the testes, remember the tunica vaginalis cavity and the tunica vaginalis membranes stick on the lateral and anterior side, so the testes is behind this. This must be the anterior side or one of the lateral sides. So the testes is underneath here and beside there. All right, so that needs to be drained. 83% of these resolve. So if your kid is born with one of these, the majority of them resolve within a year and a half after birth, about 83%. Usually by 5 months they're gone or significantly reduced. Therefore, it's recommended that neonates who have these, you don't go right in there and do surgery just to close up that processus vaginalis. You just watch them for about 18 months and see what happens. A lot of times it just closes by itself. If it's this severe, of course, they're going to have surgery to close. This little guy has bilateral persistent processus vaginalis, and the peritoneal fluid has just completely filled these during embryological days. And for some reason, they seem to be overproducing serous fluid because look at his belly button is also poked out. So there's probably something going on here. What about a hydrocele versus a hernia? So hydroceles are typically asymptomatic unless they get absolutely huge. Groin hernias are often quite painful and you can feel them. So hydroceles, usually not a big deal, but groin hernias can get really painful. And congenital hydroceles, how do you tell the difference between them? Well, if it's a congenital hydrocele, there's still, you could squeeze the fluid right out. If you take the testes, where's a more reasonable one? If you were to pinch that right now, just pinch it, you could, that fluid would go right through the persistent processus vaginalis, and it would go right into the peritoneal cavity. So you could reduce that really easily. If it was a simple hydrocele, well, if a simple hydrocele wouldn't have been pulled out, but let's just pretend it's a simple hydrocele. If you squished that, nothing would happen because there's no open communication with the peritoneal cavity. See how that works? All right. Oh, that's it. Guess we had a short part 2. All right, so that's part 2. We'll see you guys next week for the last week of this GIGU. See you later.